A couple of years ago, I had a really nice chap come to see me who'd been diagnosed after a long history of mental health problems with depression. So he figured, I'm just getting older. This is what's normal. This is what's going to happen. And so his GP gave him some antidepressants and sent him on his way. The guy came back to see his GP, hadn't felt much better. And at this point, he's saying, well, my sex drive is really struggling now. So he's like, oh, I'll have some Viagra because sometimes when you take antidepressants, that can affect your sexual function as well. So we give you Viagra on top. And the guy's now got 2 pills. But he still doesn't feel great. And then he goes back to his GP for a third time and says, look, I'm still not feeling any better. So he gets told, well, you know what? This is normal. So you just need to put up with this stuff. So he does a blood test. All his blood tests are normal. And then he goes home and the guy's pretty dejected. And one evening he's sitting with his wife and they're having dinner and they've got some friends around. And his wife's a few years older. She's late 50s. They're all having dinner together and they're talking about menopause. And the guy's sitting there thinking, oh God, my wife is always talking about her menopause and her HRT, and it's like a badge of honor because they're all on their HRT and they talk about their symptoms. It's really great. And he thinks, I don't have anything that I can link to this conversation. I just want to get out of here and sit in my room by myself, and I can't. And then he starts listening a bit more closely, and his wife's friend is saying, well, yeah, she noticed body changes and she felt depressed and she was really low and she didn't really want to have sex anymore. And you can almost say he felt this kind of light bulb moment where he went, oh my God, I'm having a menopause. Except, of course, guys don't have menopause, or kind of do they, I guess. Anyway, that was the impetus for him to go, hang on a minute. Clearly, I'm not having a menopause because he doesn't have a vagina, but he did think something hormonal is odd. And he knew it wasn't right, but he knew something was odd. So he then came to see me and said, look, I think these things are happening to me. I think it might be hormonal. What can I do? And this was the beginning of this story for this guy who ended up having low testosterone. And the really sad thing is, this is not an unusual situation. And a lot of men describe symptoms of just not feeling right because they're in their 30s or their 40s and their 50s, but they kind of get pushed into kind of a cultural narrative that says this is what's supposed to happen when you're this age. I just want to double check that you've subscribed to the show because it really helps us continue these important conversations. Thanks. Again, I'm not trying to take away anything from menopause because if it wasn't for menopause, we wouldn't have a lot of understanding of testosterone deficiency in men. But every woman's going to get a menopause. So it's really important that every doctor and every woman and men as well are aware of what menopause is. Not every guy is going to get testosterone deficiency, but 1/4 of men are going to have biochemically low testosterone. And that means that's still several million men in the UK, which means it's still definitely worth understanding. Like 20 years ago, menopause was this kind of thing where you just put up with it. It was normal and women went through it and you were supposed to suffer because you're just getting older, and HRT was a bit like, oh, is that safe? Is it good? Whatever. And then obviously that all changed. And we now have menopause cafes and we have menopause doctors and we have strong female advocates promoting female health in a way that we just never had 20 years ago. What do we have for men? Well, we've got urologists, maybe, who will sort out your prostate, an endocrinologist who will maybe sort out if you've got real problems relating to your hormones, but not really just for testosterone. Nobody really looks at male health holistically, and it's a giant gap in the market. So in the next 20 minutes, I want to try and discuss some of the specific details around testosterone so that even if we don't have those specialists everywhere, we can empower you as a patient to understand what testosterone means and what you might be able to do if you think you needed some help or want to go see someone or maybe just want to get a blood test. Testosterone is the main male sex hormone, and like everyone's heard of testosterone. But when you think of testosterone, most people tend to think of what? Sex and six packs, because that's kind of what testosterone is associated with. Like everyone knows if you want to have more sex, you have more testosterone, and you see like these videos of like absolutely jacked up guys in the gym and they're probably taking more testosterone. But testosterone does way, way more than that. So at a really basic level, obviously it's the thing that defines you as a male. Before puberty, it doesn't really do an awful lot. You get tiny little bits when you're born. It helps you make your testicles, but that's about it. And then at puberty, sometime between 11 and 14, you get this massive surge of testosterone. And if you were never really sure about what testosterone does, the best example is to think of school rugby. Certainly when I played school rugby, it's not like New Zealand where it's kind of like weight-based. In the UK, it's just you play no matter what year you're in. So if you're really lucky and you're 12 and you've hit puberty early, you gain a foot or two of height, you gain a bucket load of muscle and a pure kind of aggression and a maturity aggression that you just don't have pre-puberty. And if you're unlucky, like I was, then you can be some sort of scrawny 11-year-old playing against somebody who looks like they could have driven their own kids to play. These guys were just enormous, and it's just luck of the draw. And that's where you can literally see what testosterone does to a male. That's the outside kind of bit. So it'll make you look like a guy. It'll give you a beard. It'll give you more muscle. It'll make your bones denser. It also makes you lose your hair, but it's not actually directly related to testosterone. So actually that's DHT, and we'll discuss that later. But it does impact on that, of course. It also does give you a sex drive, but it also does other things. And testosterone influences your brain function, your personality. It influences your muscle mass. It influences your cholesterol, your blood pressure, your heart risk. It affects your metabolism. And it's also linked to longevity. So we know that men that have low levels of testosterone are more likely to die of all-cause mortality. So your risk of dying of just virtually every condition is going to go up if you have chronically low testosterone levels, which makes you think like, God, everyone should be checking themselves for testosterone. And in an ideal world, I'd say, yes, that is the case. But we don't have that luxury. And because it doesn't affect every guy, we have to try and work out what kind of symptoms they might have. So best way to think about it is we split your symptoms into 3 basic areas. We say physical ones, mental ones, and then sexual ones. So physically, you might notice that maybe you just aren't quite as full of energy as you were a few years ago. You might go to the gym, you train just as hard, but you just can't seem to gain that muscle. You might find that you eat the same food, but you're just getting fatter. And you're like, I don't really know why. I ate the same thing I did last year, but I seem to be putting on fat. You might find that your general sort of ability to last through the day starts to go down. And a lot of patients will say that they rely on caffeine to get through their day, or they might have like a mid-afternoon nap or something similar just to try and drag it along. And the really weird thing with that is you'd imagine if you don't have the energy to make it through your day, you'd have a really good night's sleep because you're so tired, but actually sleep gets disrupted as well. Sleep gets disrupted in low testosterone because you actually need testosterone to make estrogen, and it's estrogen that helps you have your good night's sleep. From a mental perspective, you kind of associate high testosterone with aggression, and we think that like all these super high-end athletes or murderers or fighters or anything like that will have really, really high levels of testosterone because it makes you more aggressive. But actually the evidence is that's probably not true. We actually think that either end of the spectrum is bad for you. So imagine testosterone is like a Gaussian curve of health. So it's like a hill. And if you have too much testosterone, it's probably going to make you unhappy and you'll get irritable and angry, but not necessarily aggressive. And if you have too little testosterone, the same thing happens. You get irritable, angry, and you get a bit aggressive, but not in the same way. What you really want to do is keep your testosterone in that sweet spot in the middle. And that's how it affects your mental health. So it affects your mood, but also testosterone affects your personality. And sometime in your mid-teens, when testosterone starts to really kick in, subconsciously, whether you like it or not, you are going to start thinking about sex. And evolutionary wise, testosterone is going to subconsciously drive this through the rest of your brain for nearly the rest of your life. So the way testosterone works is it affects several areas in your brain that are related to your sex drive and sex function. And once you start getting more testosterone, these areas suddenly all get lit up. And you can see this on functional MRI scans. So they did these really interesting but slightly pervy studies where you get a guy and they show them pictures of attractive people in various states of undress, and you can see which parts of the brain will light up on a functional MRI scan, and then you can work out which areas of the brain are stimulated by sexual activity. And we know that these areas also have testosterone receptors because you can measure those as well by biochemical levels or some fancy tests looking at where receptors are in the brain tissue. And we know the two match up very nicely. Whether you like this or not, for the next decades of your life, several decades at least, you're going to be subconsciously driven to want to have kids and procreate. And you may not feel this is a conscious thing, but this is where the sex part of testosterone comes in. So testosterone is going to make you want to have sex. It will give you libido and desire. It won't be the be-all and end-all, but it certainly contributes. And it'll also give you erectile function. If you don't have any testosterone, you will not get an erection. But you can still have normal erections and have low testosterone. You can have a decreased libido and still have normal testosterone. And in fact, you don't have to have all 3 of these at all. You can just be suffering with one area. What determines which one is it going to be, or whether it's going to be all 3, tends to be how bad or how much of the testosterone you've dropped, and maybe just what you're particularly influenced by. Going back to sex again, we know that, for example, free testosterone is particularly linked to sexual desire, and testosterone overall is a really good indicator of desire and libido compared with, say, physical symptoms, which might be a bit more sort of hit and miss. If you can't remember the last time you had regular morning erections, that is a proper, really good red flag to say, I might have low testosterone. So in a normal day, you naturally have a peak of testosterone in the early hours of the morning, say, I don't know, 3 till 7, 3 till 6, something like that. And that's where you naturally surge of this stuff comes out. And that gives you a morning erection. So a lot of patients will come in and they go, oh, I only woke up because I needed to pee and that gave me an erection. You're like, no. You woke up because you needed to pee. The erection was already there. And that's a good, healthy sign that those testosterone levels are being spurted out each morning. You can get other little spurts of testosterone. You can do that by doing things like being physically active or having certain foods will depress it very slightly. Sex does temporarily increase your testosterone, but it's kind of like cancelled out by oxytocin and prolactin and a couple of others. So you can't sort of sex your way through to high levels of testosterone, although wouldn't that be really cool if you could? So you can look at patients' morning erections as a really good indicator of sexual function. One of the really interesting things is that most guys won't think about drops in or a drop in morning erections until you ask them. So in your 20s, most guys will probably get morning erections most days of the week. And then over the years, it slowly starts to drop down as your testosterone starts to drop. So typically in guys, we say, but from the age of 30, you're probably going to lose about 1% a year, which is not a major amount, but it does start to add up. So a lot of guys in their 40s, if you're healthy, I would still say to you, you should still have morning erections once or twice a week. Same in your 50s and 60s. But if you look back and think, hang on a minute, I can't remember when that happened, then that's a really good indicator you need to go to get that tested. So when we talk about this drop of testosterone, 1% isn't actually very much. And if you think about the normal levels of testosterone for a guy in the UK, so we use different units, but we would say an optimal level is around 15 to 30 nanomoles per litre. We would diagnose you as having low testosterone below 12 nanomoles per litre, but there's a kind of grey area of 12 to 15, whereas if you have certain metabolic conditions like diabetes or you're highly symptomatic with other symptoms, then we might consider you for treatment. And then we also talk about free testosterone as a diagnostic factor as well. And just to clarify, total testosterone is just the amount you produce from your testicles. So it just gets spurted out, goes into your bloodstream and it flows around. Free testosterone is the amount you can actually use. And free testosterone is different because most of the testosterone in your blood, like 97% of it, is actually stuck to these binding proteins. One of them called sex hormone binding globulin or SHBG, and the other one called albumin, which most people have heard of. And these kind of stick to your testosterone, and then they're supposed to release it when they need to. But actually, if you think about it, only 3% of your total testosterone is actually usable. So if those other proteins like the SHBG or the albumin get changed, then it doesn't really take much for your free testosterone to get squeezed even more. And so then you've got another person who's got low testosterone. Anyway, point is, a free testosterone level is defined as low if it's below 0.225 nanomoles per litre. Now, these are only useful because they don't always match the NHS references, and that's often because different deaneries or locations in the UK will have different individual reference ranges. But the British Society of Sexual Medicine and the Endocrine Society for total testosterone both agree on the fact that we should be looking at free testosterone 0.225 and a total of 12 or 15, depending as your total. When it comes down to you saying, well, do I get a free testosterone? Do I get a total testosterone? How do I know what to go ask for? Practically, if you have a low total testosterone, well then I don't really need your free testosterone because it's low and it's easy. We know you've got low testosterone, great. If you've got a normal total testosterone, but you think, hang on a minute, I've got all those symptoms we talked about. We've got the physical symptoms. I've got brain fog. I'm irritable. Everyone hates me. I hate everyone else. And I've got no sex drive and no morning erections. Then actually that's the time to say, well, now what's your free testosterone? Because maybe your total's okay, but all those binding proteins are so high that they've squeezed your total and you can't use any of this stuff and it's all bound. And therefore it's definitely worth asking that question. So I always say to a patient, if you feel like you've got low testosterone and you've gone to your doc and they said your total testosterone's fine, ask about the free, because that might be a really useful next thing in terms of what to do. Have a suggestion for a Man Alive episode or thought about something said in this episode? Comment below and I read every one. If you do get diagnosed with low testosterone, then a lot of patients will say, great, now how can I avoid having to see someone like me? So, which sounds weird, but I think generally men are quite averse to having medicines and treatments, and they'll do anything in the idea they're hoping they can kind of lifestyle their way out of this. And that is true to a degree, but could you imagine if you went up, using menopause as an example again, if you said to a menopausal woman, well, I appreciate you're going through full menopause, but if you just, did a bit more exercise, ate a bit better, maybe had some more sex, you'd be happier. And I don't think many doctors are going to say that. And I think that's a very quick way to end up in front of the GMC losing your license. So I think we shouldn't be thinking about testosterone deficiency as purely a lifestyle problem. There are lifestyle things that contribute to it, but it's not the only thing. So briefly, I'll come on to causes of testosterone, and then we'll look at how we can try and manage it from a lifestyle perspective. But effectively, there are kind of three causes of low testosterone. One's called primary hypergonadism, which is the medical term. One's secondary hypergonadism, and one's age-related or functional. Interestingly, we never use the terms primary hypergonadism when you talk to your patients very much, because no guys want to go home and tell their mates, oh, I got a diagnosis of primary hypergonadism today, because it doesn't seem to be particularly, doesn't roll off the tongue very well. So we tend to say testosterone deficiency. The other reason we don't use hypergonadism is because it's quite a medical mouthful, and the media prefer things that we can use that they can help understand. And that's where the term male menopause came from, or menopause or andropause. But of course, none of it actually really exists. But if you're trying to define a new condition that nobody really knows about, well, if you said, look, it's just like menopause, so we'll call it something like that to help you understand what it means. And they went, oh, it's menopause. Brilliant. So that's great. So yeah, now it's menopause. But testosterone deficiency is kind of what we want to use. Primary hypergonadism means the problem's coming from your testicles. So for whatever reason, your testicles are not producing enough testosterone. And we see that in patients maybe who have had testicular injury, patients who have congenital or genetic problems whereby their testicles don't form properly, or we might see it in patients that have had testicular problems such as having mumps because they haven't been vaccinated, and it's called orchitis and damage to the testicles. And we'll see it in things like testicular cancer, where it directly damages the testicles themselves. Secondary hypergonadism is far less common, and that's where you have a problem often to do with the brain that stops you producing the precursor hormones that then affect your testosterone. So if, for example, there was something like a pituitary tumor that might affect your brain function, that might stop you producing the signal that says, now I want you to produce your testosterone from your testes. And we do still find that. Having lots of tests done to find out which of the two causes it is really important, because if you can find the cause with testosterone deficiency, you may not need testosterone. You might just need to fix the underlying thing, and then it might get better. The other cause of testosterone, which is the main one we're now starting to see in a growing population, is functional or age-related. And this is kind of like Buckaroo, the game that you play with a kid with a donkey and you load it up with little things each side. This is the best analogy we're going to get on this. So if you imagine in Buckaroo, the Buckaroo is your testicles, and each time you load something on the donkey, it has another impact on your testicular function and your ability to produce testosterone. So supposing you're just getting a bit older, and that's one tick on the box, and then maybe you've got a bit fatter, so you don't produce as much testosterone, and being obese causes estrogen problems and insulin insensitivity, or which decreases your testosterone, so that is like another tick. And then maybe you take some medicines, just maybe some painkillers or some antifungal treatments. That's another tick on it. And you can see lots of little things, because loads of medical problems, like certain high blood pressure treatments, types of asthma treatment, asthma itself, kidney disease, types of anemia, thyroid disease, chemotherapies. And you can keep adding these little things. And because we're aging, we add little things each time. And even from the lifestyle side, well, maybe you don't get to the gym quite as much as you used to, and you don't quite eat as healthy as you used to, and you don't get those nights sleep because either your wife's having night sweats, or maybe because you've got young kids or you're working hard. And eventually your testosterone drops and drops and drops until that donkey kicks. And that's just like that kind of Buckaroo effect. And you'll cross a threshold where you just think, my God, I feel awful. And because these are all insidious and slow, and they pick away at your testosterone, often you don't think, wow, I've just suddenly had a sudden moment when my testosterone dropped. It's all very slow, and a lot of patients will describe a gradual decline in how they feel over several years, which is why the average time it takes for a patient to come and see me following the start of their symptoms is about 2 to 3 years, which is insane. Because could you imagine, like, if somebody said, oh, I've got, I don't know, really bad eczema, and they went, oh, I've got really bad eczema on my elbows, but I waited 3 years to see my doctor because I thought it's just normal. And you just wouldn't do that. If we have your diagnosis, the next step is, what can I do? And as I said before, most guys will do anything to avoid having to see me. So the first thing you always say is, what can you do to boost my testosterone? How can I improve it myself? One thing you can do, which generally has really good evidence behind it, is exercise. And we know that exercise has got really good data, not just in terms of longevity and general health, but if it's intensive enough, it will cause a metabolic drive and it will help improve testosterone production. And by intense, I mean you need to be doing about 45 minutes, about 3 times a week, and ideally more if you can, but I appreciate it has to fit in real life. In terms of which exercise, a lot of guys will say, well, I assume it has to be weightlifting because that's the thing that's going to make you big and stacked, but actually the evidence doesn't show that. It just needs to be intense. So you've got to pick something that you're willing to stick at, that you can do hard enough to either make your heart rate go up or to make you sweat or to make you feel sick or like your muscles hurt or then maybe they're sore the next day or something. And that's the key to get that metabolic drive. And that's the first thing. Exercise is massive. And the next one is body weight. And we have to remember that whilst there is a progressive and positive measure in normalizing body shape around the UK, which we didn't have 10, 20 years ago, obesity is still generally very unhealthy and it does massively increase cancer risk, heart disease risk, diabetes risk, and also significantly impacts on your ability to naturally produce testosterone. And that's because obesity increases estrogen, and estrogen is the direct antagonist to the testosterone because the two don't like to be together. It will feed back negatively. You'll get insulin resistance, and obesity itself actually sends signals to your testicles to say, let's just reduce the testosterone a little bit. So a healthy body weight's really important. What you eat is also important, but in the UK, we have very few people that are generally micronutrient deficient. You know, it's unlikely to say you don't get enough protein in your diet. Most can survive on normal levels, adequate levels of protein. We do see micronutrient deficiencies in some people. I once had a very interesting case of a guy who was in his 80s, who'd presented with bleeding from his gums and his nose, and then spontaneous bleeding in his joints. This was not testosterone related, by the way. It was a friend of mine who's a hematologist, and he actually was diagnosed with scurvy. Scurvy, the classic, obviously, pirate 17th, 18th century ship's disease, which you get from not having enough lemons or vitamin C. This guy had eaten nothing but digestives and tea for a year because he was by himself and he was an elderly patient and didn't feel that vegetables or fruits offered any value to his day. But of course, micronutrient deficiencies do occur in the UK. Assuming you're not planning on bleeding from every joint and you're not actually going to be eating just digestives and tea, things you can do as a guy are to make sure you get enough zinc, enough selenium, enough magnesium, and enough protein as an overall. But it's not hard to achieve. And a few different fruit and veg a day, you know, they say 5 a day, it should ideally be more. But if you can just achieve almost that, you'll be absolutely fine from your testosterone production. Very few men, unless you're at a very high athletic level, or unless you are naturally deficient due to a medical condition, will actually need supplementation in these. So you should be pretty much fine to go. I did mention sex, and sadly, sexual function won't increase your overall total testosterone production, but it will reduce your risk of prostate cancer. And there was a great study in 2016 that showed that men that were sexually active and ejaculated more than 21 times a month could reduce their risk of prostate cancer by a whole third, which is amazing. It didn't stipulate whether there was a partner or another person involved in the study. So unfortunately, you can't use that as a reason to start flashing some piece of paper in front of your wife to say, look, you can help cure my cancer. But we can say that being sexually active a minimum of 21 times a month, and it actually, you could keep going if you wished. I don't know if that would decrease your risk further. It depends what other day-to-day activities or job you have to do, could potentially reduce your prostate cancer risk even further. The other thing you can also do is get some decent sleep. So we used to say 7 or 8 hours is fine. And then there's this whole drive to say, are you getting enough sleep? We now know that actually having more than 8 hours can be detrimental for some men, and actually having 9 or 10 hours is actually quite bad for you as it disrupts circadian rhythms and has other detrimental effects on your health. So 7 or 8 hours is fine, but it's not the total that counts. It's the quality of the sleep you get. So you can't catch up by having a nap late in the afternoon and go, oh, it's okay because I got my 7 hours. It doesn't work like that. You need repeated cycles of sleep because, you know, we have these cycles of sleep where you go to deep sleep, light sleep, REM sleep, and you have cycles through the night. You need to get through these cycles to eventually reach a point in the early hours where your pituitary gland goes, right, that's it now, he's had enough, I'll stimulate that LH to start his testosterone levels surging. So you need to have constant, good quality sleep. So many guys will say that when they've got newborn babies, they come in and they kind of go, oh yeah, no, I'm up all night, I'm helping my partner, and I sympathize because I don't want to have sex at the minute either. because I'm in the kind of like this paternal phase, and it's like, I know she's breastfeeding, but I feel like my milk hormones are there, and you're like, no, some bollocks. It's because you're absolutely knackered because you're helping doing a night feed, or because the baby's crying and broken your sleep, so your testosterone is down, and that's why you don't want to have sex. I'd love to say it was something closer about bonding, but I don't think it really is. The big thing about testosterone and improving your levels naturally is that there is no magic supplement or one simple life hack that you can do that will just suddenly make your testosterone levels better. I mean, all those things I've said kind of are like simple, easy things to do. But because we talk about diet, exercise, sleep, reducing stress, which is another big one, all the time, they kind of lose their meaning. And if they lose their meaning because you hear it all the time, you're like, well, no, I don't really want to do all that. That's a lot of hard work. Is there just a pill? Now, one of the things that we did talk about was stress, and chronic stress is particularly bad for your testosterone. There is a theory that a tiny little bit of stress is good. So if you were a caveman, you might be sitting there in your cave village with your cave friends, women friends, and you might be thinking, I'm pretty relaxed. I've got very little cortisol, which is your stress hormone. So your testosterone is nice and high. And then, of course, you get attacked by a saber-toothed tiger, which is just what happens, apparently, in evolutionary history. And then you've got to have a surge of cortisol, and then you'll also get a subsequent surge of testosterone after, so you can fight and live to survive another day. And then after that, your cortisol levels drop, your testosterone surging, and you might celebrate by copulating with one of the local tribes people. But the problem is that's a brief surge of cortisol. Cortisol is an antagonist to testosterone. So if your cortisol goes up, it stimulates a lot of the body's stress mechanisms to make sure you're ready to run if you need to. But that's not the same as testosterone. Testosterone is an anabolic hormone, so you need it to make muscle. So it's going to want you to ingest food. It's not going to want you to have to fight at the time. Testosterone is a sex hormone, so it's going to want you to have sex. You cannot think about fighting a saber-toothed tiger if you've got an erection. So it's really important that the two are not linked together. In modern society, we don't have that initial stress of being attacked by wild animals in the same way. We don't have to worry where our next meal is going to come. So we have adapted poorly to how we manage our stress, and therefore lots of people have chronic raised cortisol levels and chronic stress and anxiety, which means their testosterone is just tanking all the time. Now, I appreciate it's very easy for us as doctors to say, well, just reduce your stress, but you can't always do that in real life. And that's why, as much as I include it in the things to do to improve your testosterone, I'm also aware that sometimes you just have to be aware of what real life is. So in terms of supplements, just very briefly, because there's a lot of them out there, there's things like tribulus and fenugreek and lion's mane and ashwagandha and just testo boost. And there's amino acids. And the evidence for almost all of these is that they will do virtually nothing to your total testosterone production. The only one that's got some suggestion around testosterone levels is ashwagandha, but ashwagandha again has very limited data around 12 weeks only. We don't know if it does anything after the 12 weeks. And if you think about how much it's really going to do, it's a very, very small percentage increase on your total testosterone production. So nobody is going to go to a health food shop, buy some ashwagandha and come out looking like Arnie Schwarzenegger in the 1980s. That's not now because he's quite old, but in the old days. So no one's going to look like that. So if you are going to take this stuff and you have a low testosterone level, it's going to do nothing, because again, you can't have someone with a true medical condition say, well, if you just take a bit of a supplement that might increase it by a couple of percent, it'll fix everything, because it won't. So as much as I said, going back to my original point, I want to avoid seeing the doctor, you can't. And if you truly have a low testosterone, we do want to fix, and you should address all of these lifestyle things. And that is really important. But if you've done all of that and you still have low testosterone, then you have to think about testosterone replacement therapy, and that's TRT. Now, TRT is a synthetic external testosterone that we give you, and it's designed to replace the testosterone that you should have had to get you back to what you should have had for your age, or around where that will be. That's why it's called TRT, testosterone replacement therapy. Very similar to HRT. In fact, it's the same with a different first letter. So the principle of it is that you cannot produce this amount of testosterone yourself. Therefore, we are supplementing what your body should have had to get you back to an age-related normal. if we give you too much of this stuff, then it's just like giving people steroids. And we don't want to do that, because the whole point of TRT is to make you healthier and not to overshoot you too far that bad things happen. And again, just like I talked about with mental health with testosterone, the whole thing is the same with testosterone replacement. If you have low testosterone, you have all those symptoms we discussed, your increased risk of cardiovascular disease, diabetes, osteoporosis, mental health problems, probably dementia. We haven't quite confirmed it yet. Relationship issues, sexual dysfunction, skin problems, hair problems, eye problems. There's loads of stuff. And then we give you testosterone. It goes back into that normal range of 15 to 30, and you feel brilliant and like, wow, this is awesome stuff. And then you overshoot because you think, well, more is always better, but it's not. Because if we start to go too far the other way and we just gave you, I don't know, like 10 times the amount, and you had enough to be some sort of crazed rhinoceros, then it's not going to help you. All that happens is that your testosterone receptors get saturated to a point. Your muscle mass will obviously go up, but that doesn't make you healthier. And then it increases the risk of heart disease again, your blood pressure, your cholesterol. And it also increases the risk of a thing called polycythemia, where you just make too much blood. The other thing to be aware of course, with testosterone replacement is it does impact on your own natural production. So we can give you medicines that will help protect your own testicles and your sperm when you take testosterone. And we call these things either HCG or AIs, sometimes with the aromatase inhibitors, and they can improve fertility, but that's a slight separate issue. We give you things like Clomid or clomiphene, which are called SERMs, and these help just retain and manage your own testicular functions, so you still produce testosterone as well. Because if we didn't give you any of that and we just gave you testosterone, then your brain says, well, I've got loads of this stuff now, so my testicles don't need to produce it anymore. And then they will start to shut down a bit. And that can be tricky, especially in younger people. So if you're 50 and you've had your kids and you don't want any more kids, and not many of my 50-year-old friends want any more kids, then you can just give them testosterone. And for most guys, that's absolutely fine. They may want to take some clomiphene or eclomiphene or something or similar to produce some natural testosterone just to keep things ticking over, but it's not so important. If you're 22 and you had true low testosterone and we were trying to preserve all of your natural production as much as possible, well, you would want a small amount of testosterone and a lot of the other things, the HCGs, the clomiphene, because we want to try and get your testicles to be as good as they can be so that it doesn't impact on what you might do in the future and wouldn't also affect your fertility, because it's really important when you're young. There are newer medicines starting to come through, which are actually looking like they can preserve that better. And it might be in the future that we have tablet-based ones that can help preserve testicular function. But at the minute, it's a little bit more nuanced. And that's why, again, I don't really want people with low testosterone going, right, I've got my diagnosis. Now I'm just going to go to the back of the gym and buy some testosterone from a guy called Steve in a van, and we'll just see what happens. And hopefully all goes okay, because these are a lot of the people that we do see in clinic a few years later when bad things have messed up. In terms of safety for testosterone, unsurprisingly, testosterone replacement treatments have been some of the most studied medicines out there, often because there is a kind of media or cultural concern whether it's a safe thing or not. And that was kind of born out of the bodybuilding era of the 80s. And even prior to that, in the 1940s, when testosterone cypionate was first invented, which is one of the first testosterones, it was shown to be really successful. And then there was this very small study that potentially linked it to prostate cancer. And suddenly that just became the norm. Everyone thinks if you take testosterone, it's going to cause prostate cancer. But I can categorically say, thanks to things like the Traverse study, which is very new and looked at thousands of men on testosterone, it has no link with prostate cancer whatsoever. So that's fine. The other issue was heart disease. And again, the Traverse study was an amazing study done in the US a couple of years ago, and looked at thousands of men, and they gave half of these guys who had pre-existing heart disease, so they'd had a heart attack, or they were at risk, so they'd had high blood pressure, cholesterol, diabetes, or they are angina and they were going to have a heart attack. And they gave these guys testosterone, and they compared that with a group that didn't have cardiac risk, and there was no increased risk of cardiac events. So we can suitably say that testosterone is safe for people that have had heart problems, except for certain types of heart failure, but that's different. It doesn't cause an increased risk for those that have cardiac risk already. And we think, although we can't quite prove yet, that it's probably going to be even cardiac protective. Current treatments are really successful, and We use injections, we use gels, and sometimes we use tablets, depending what that is. I'm not saying that every guy needs to have testosterone, because obviously we know that it's only a quarter of men that will have biochemically low, and that may not be every guy. But the thing about testosterone, and the reason I like doing this job, is because it's a massively rewarding specialty. If you get someone who's felt awful for a couple of years and they don't know why, and they've been everywhere and all the specialists have tried, they just cannot find a cause, and you give them this one single drug and it makes their body change, it makes their brain change, they feel happier and they love their life again and their loved one loves them again, and it's a life-changing drug. And for that reason, it's really successful, and why I'd recommend that every guy who isn't sure should probably go get themselves tested. Do you have a mate who's going through a rough patch right now? Share this with them today, because one conversation can change a life.